All right, thank you everyone for joining us for today's South Texas Regional Family Medicine Grand Rounds. Our educational partner is the South Central Area Health Education Center. Our department's mission statement, inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaged in the session, keeping cameras on when appropriate for our Zoom attendees, registering for CME credit for each session, and for completing and submitting a session evaluation form. Today is February 21st, 2024, and today's activity code is 10093237. You can claim this CME credit via text by texting your email address to the toll-free number 844-502-1338, and then texting attend 10093237. You must register for each session by midnight in order to receive credit. Here's some information on the new CME credit system. Again, today's activity code is 10093237. All right. You can use the instructions on the screen to access your CME transcripts from the Long School of Medicine CME office. You can also claim credit on the AAFP using your AAFP login and the link on the screen. This live activity, South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the AAFP. Physicians should claim only the credit commensurate with the extent of their participation in the activity. The Family and Community Medicine Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. Our presenter today, Lizette Lugo, has no financial relationships with ineligible companies to disclose. And now Dr. Nato will introduce our speaker.
So this is a real pleasure for me to introduce Lizette Lugo, one of our outstanding third-year residents, 2% Grand Rounds. Lizette was born in Laredo, Texas. She earned her doctorate of medicine degree from Texas Tech Health Science Center in El Paso in 2021. She's currently a family medicine resident at UT Health San Antonio. She is part of the clinical educator track and the health system science track through the general medical education and the Department of Family and Community Medicine. Dr. Lugo will serve next year as the institutional chief of the health system science for the University Hospital and for UT Health. Lizette is going to discuss approaching acute low back pain as a PCP.
Thank you. Okay, so the title of my presentation is Approaching Acute Low Back Pain as a PCP, and Dr. Camacho is my advisor for this presentation. So some of the objectives that we'll hit today is defining what acute low back pain is, identifying red flag findings for back pain, and then analyzing which oral NSAID is superior for the treatment of acute low back pain. So why is low back pain important? It affects about 80% of adults in the United States at some point in their life. It is actually one of the most common visits for patients to present to their family physician. Family physicians actually treat more patients with back pain than any other subspecialists combined, so more than ortho, more than neurosurgeon combined, and it is the leading cause of disability worldwide. More than 80% of patients will have non-specific pain, which just means that there is an absence of an underlying condition that can actually be identified for back pain. It's very common. So what is acute low back pain? So pain that occurs in the regions between the lower rib margin and then the proximal thighs, that is less than 6 weeks in duration. Risk factors for back pain are smoking, obesity, age, female sex, a physically strenuous job, dissatisfaction with their job, anxiety, depression. So like everyone in the US has at least one of these risk factors. So let's go over some terminology that you may have seen or heard of when looking at back pain, trying to select an HCC code, reading reports for back pain. So spondylosis is like the new term for arthritis of the spine. It is a disc narrowing between the facets of the joints. Anterolisthesis is the anterior displacement of the vertebral body relative to the one below it. Spondylolysis is fracture of the pars intra-articularis, where the vertebral body and the posterior elements are protecting the nerves. Spinal stenosis can be local, it can be segmental, it can be generalized vertebral bone narrowing. And it usually happens with bony hypertrophy in the facet joints. And then radiculopathy is an impairment of a nerve root that can cause radiating pain, numbness, tingling. Sciatica is pain, numbness, and tingling in the distribution of the sciatic nerve. And then cauda equina syndrome is the loss of bowel and bladder control and numbness of the groin and the saddle area with the perineum associated with weakness of the lower extremities as well. So again, this is just kind of terminology on when you've seen like reports, when you've seen different things when you're trying to select your HCC code, it like makes you pick like acute or chronic back pain with radiculopathy, with sciatica. Those are the definitions that we can use. So important for physicians when you're taking the initial history for determining like what is important and what is not important, or what can affect the patient's like urgency to be seen. So our goal is to identify somebody that needs emergent surgical evaluation, an underlying infection or malignancy, and then signs of cauda equina. So location, duration of the back pain, severity, history of prior back pain, how does it compare? The current back pain, how does that compare to the past back pain? If there was a mechanism of injury or trauma, any constitutional symptoms like weight loss, fever, night sweats, if the patient has a history of malignancy, neurological symptoms, which can be like the radiation of pain, the numbness, the tingling, the weakness, loss of bowel function, and then any social or psychological stress as well. So physical exam, important to inspect the back, and inspect posture, palpation and percussion of spine, the neurological examination as well, like reflexes, strength, sensation, gait, the straight leg test, which can help with sciatica, determining sciatica as well. And then there are other, which I'd never heard of, Waddell signs. So overreaction during a physical exam, superficial or widespread tenderness, inconsistent, supine and seated, straight leg test, and then unexplainable neurological deficits as well. And then for those of us that have worked with Dr. Persani, have probably seen this slide many a times. And that is a radiculopathy that can kind of happen with certain levels of the back pain. And so that'll help with determining the radiculopathy and then what level is being affected. So very common for L4, L5, and S1 to be affected. And then depending on where the patient is experiencing pain or experiencing the neurological symptoms like the numbness can kind of give you an idea of where that level of injury is. And then red flag symptoms again. So what we are trying to figure out is if somebody needs emergent surgical evaluation or treatment. So major or progressive motor or sensory deficits, the new onset of bowel or bladder incontinence or urinary retention, saddle anesthesia, increased pain at rest, a history of osteoporosis, history of spinal surgery, history of cancer, significant trauma, someone that has a prolonged history of steroid use or immunosuppression, someone who uses IV drugs or has a history of IV drug use, and then suspected lumbar stenosis and intolerable symptoms. So actually, labs and imaging are not required unless you suspect some of these things. So if you're suspect an infection or you suspect malignancy, then you can order a CBC or an ESR or CRP, which are markers of inflammation or infection. If a patient had significant trauma, then you can go and order plain x-rays, and you can order an MRI or refer for emergent surgical evaluation. Again, if the patient has some of those other symptoms of cauda equina, like the bilateral sciatica, the leg weakness, or the difficulty urination or fecal incontinence. We don't usually do CT scans unless there's a contraindication to an MRI. So if the patient has like a metallic implant or something like that, that's when you would order a CT scan. So the diagnosis, the differential diagnosis for low back pain is very broad. The most common is the mechanical low back pain, which is like the muscle strain or sprain. And that can happen with patients that have like repetitive or overuse. So again, that's when the history is like important. So if they are someone that was moving and they like pulled something, or they had pain after an activity like that, and that's been relieved by rest, their physical exam will also reveal that they have restricted range of motion, or they have muscle tenderness, or they have like trigger point tenderness when you do their physical exam. Again, we talked about some of these, like the spinal stenosis and spondylolisthesis. And then again, those other conditions are less common, but those are the ones that we worry about. The neoplasias, inflammatory infection. And then because we're family physicians, always super important to remember that people have other organs in this area. And so they may be presenting with back pain, but really it can be a symptom of something else, like a GI issue, renal issue. So guidelines for treatment, the ACP and the AFP have created a guideline recommendations for treatment of acute low back pain. And so NSAIDs are the first line treatment. So there have actually there's a whole bunch of studies that kind of show differences between NSAIDs. And so NSAIDs have shown an improvement in intensity and pain, and a small improvement in function when compared to placebo. But when they compare head to head, like oral NSAIDs to one another, they've found no difference. So there's also no difference between COX-selective 2 and traditional NSAIDs. But we have to remember that even though this is the first line of treatment, a lot of our patients do have GI or renal issues that would disqualify them from using NSAIDs. So the study that looked at oral NSAIDs was a 3-armed double-blind comparative study. And the way they selected for patients to choose was patients that presented to the ED for a complaint of low back pain that had been going on in 2 weeks or more of duration. And they were discharged with an oral NSAID and then a patient education packet. And there were 3 arms. So one got ibuprofen 600, one got ketorolac 10, and then one got diclofenac 50. And they concealed the medications by putting the tablets into capsules that all looked the same. And so it was blinded to the people doing the study and the patients themselves. And then they called the patients after 2 days of discharge and after 5 days of discharge. And they had like a 24 questionnaire asking about pain, asking about function. And they found that there was improvement with everyone who did NSAIDs, but there was no difference between the 3 NSAIDs. And then they also asked about stomach irritation, and they found that there was no significant finding of stomach irritation on the questionnaire between the NSAIDs. Okay, so other forms of treatment that we often prescribe are Tylenol. And it's actually shown that there's no benefit from giving Tylenol compared to placebo. But it is a favorable safety profile, and it's relatively low cost. So that is kind of when you have to decide whether the patient qualifies for NSAID or they would be a candidate for NSAID or not. Topical anesthetics like lidocaine and capsaicin also have no benefit compared to placebo for improvement of back pain. Opioids have shown to improve back pain, but should only be used 2nd or 3rd line and should only be used in short term. There's no advantage between NSAIDs when looking at symptom relief or function when compared to NSAIDs. And then obviously they have a lot of side effects like pruritus and constipation, potential for abuse and addiction as well. And then looking at other types of treatment like skeletal muscle relaxants. So 2 meta-analyses have shown that there is strong evidence that the muscle relaxants improve and are helpful in the treatment of back pain. They are most beneficial when added 1 to 2 weeks in the start of the back pain. And there's also shown benefit when used in combination with an NSAID, but also have side effects of drowsiness, dizziness, nausea, and potential for addiction and abuse. The other treatment that has been looked at is steroids, systemic steroids. A lot of emergency rooms actually use steroids for the treatment of back pain. And it was found, so for non-radiculopathy, non-radicular back pain, there's no difference in pain control. But when patients have radiculopathy, steroids have been found more effective in the short term than placebo. So a short course does not appear to have any harm. So if your patient has symptoms of radiculopathy, this may be a good option for them. And then heat or ice. So it's found that cold therapy is minimally useful, but heat therapy has been found to be helpful in reducing pain and increasing function. And then trigger points. So when compared to IV, NSAID, or standard of care, trigger point injections do reduce pain by 2 or 3 points on a 10-point scale. This is also showed to be beneficial. And then bed rest, which is actually a thing that most patients think would be helpful, has no benefit. And staying active rather than staying in bed has shown that there's less time missed from work and improved functional status and pain too. So we should not recommend bed rest. When looking at exercise therapy and physical therapy, specific back exercises were actually not helpful. And it was very difficult for a lot of studies to determine whether physical therapy was beneficial or not, because the intervention will differ, the exercises will differ, traction will differ, what they use during the aftercare was also different. But there is kind of consensus that the McKenzie method has been shown to be beneficial, and I'll get into what that is. And the McKenzie method has shown that there's short-term pain relief, but not long-term benefit. And then for massage, there was insufficient evidence to determine if this would be helpful or not. Acupuncture, so limited evidence, but they do have some moderate evidence that it can be not beneficial. And then some smaller trials have found that it can be beneficial in patients with sciatica. And then manipulation, also very different, very hard to determine if it's going to be beneficial or not, because everybody kind of provides different care. So it's not shown to be beneficial. So the McKenzie method of physical therapy is an individualized self-treatment program, and it's a series of progressive positions. So the patient will start by laying prone on the floor, and then if they're able to tolerate that, then they move up to the next position, which is like laying prone but on their elbows, and then they push up, and then they can use pillows, and all the way up to standing extension. And this method has been shown to be beneficial with acute short term, but really, again, no difference in long-term or chronic back pain. So this is an assessment that's done with a physical therapist, and it shows the patient's symptoms and mechanical responses, and they kind of just push that end range of motion for the patients. So returning back to work, when should patients return back to work? So we talked about how bed rest is not what we recommend, and it's shown to have no benefit having patients stay home from work, and also it actually worsens your function and worsens the disability if you stay home from work. So it really depends on the patient's activity level and then what they do for work, whether they should stay home from work or not. So we recommend continued activity unless the patient has a very strenuous job where they do a lot of heavy lifting or something like that, then they can return to work, but with modified duty. There is a screening tool that we can use as PCPs called the Start Back Screening Tool. And this questionnaire is helpful for us to determine if the patient has high risk or medium risk for their pain to become chronic. So they ask a lot of questions in this questionnaire, but it's like, does the pain like radiate down your legs? Have you been able to walk? In the last few weeks, have you had decreased function, excessive worrying about this stuff? So again, some of those risk factors that we talked about put you at the medium risk or the high risk based on your points too. And those are sometimes we call them yellow flags. So yellow flags are risk factors for prolonged disability. So we have to consider like the biomechanical, the psychological, and the psychosocial aspects that can put patients at risk for their pain to become chronic. And then I have everyone has to do, but to get your, after you get your Texas license, you have to get your DEA license as well. And you have to take an opioid course for prescription of medications. So there was a question on it. It says a patient presents with low back pain that has persisted since the initial inciting injury a month ago, despite Tylenol, NSAIDs, and PT. Which of the following characteristics, if present, would increase this patient's likelihood of developing chronic back pain? And after everything that I kind of said, is there an answer that sticks out to you? Yeah. Anxiety. So acute pain is a normal physiological response to an acute injury or inflammation, and it serves as a marker that there's healing and survival. But in most cases, the pain will resolve. Again, some psychological factors like anxiety, stress, depression, those have all been linked to chronic pain. And again, this is everything that I kind of talked about is for acute pain. So I wanted to make that distinction because I know that a lot of our patients deal with chronic pain and that treatment is different. But in summary, acute low back pain is very common. It is something that we will see a lot as PCPs, and you don't need to order labs or imaging for the pain unless, again, they have those red flag risk factors. And the first line treatment is oral NSAIDs, and there is no difference seen clinically with different oral NSAIDs. So you can pick any of the oral NSAIDs as your first line of treatment. And that's it. That's my presentation. Yeah.
Was it that was says that was it 25% acute pain?
Yeah, 25%. 25% of acute becomes chronic. Yeah. Yeah.
And what are
the length of time? So there's like acute, which is 6 weeks, and there's the subacute, which is the 6 to 12 weeks, and then 12 weeks and beyond is chronic.
This age is
Yeah, older age, yes.
Well, they're studying on different dosages from the insect.
It was like the maximum. I didn't find a study between like different dosages, but it was because of the side effects. It was the max tolerated with the least side effects, and that's how they decided on the ibuprofen 600, the ketorolac-10, the tacrolimus 50. Yeah. Usually those people are immunosuppressed, and that's why they're on prolonged use of steroids. So, yeah. Any other questions? Hey, thank you.
So before you go, thank you for the outstanding grand round. Just want to present you with the highly sought after, seldom presented, but always treasured
Yay.
family and community medicine challenge.
Thank you. Woo.